Dubai, good morning, GIS. I'm very proud and happy to
The sound, please.
participate, even virtually, and I'm very thankful for Dr. Fawaz and all the organizers of GIS 2024 to invite me for this edition. My task is to present quickly a year in structural intervention, and I'm going to focus on valve disease. These are my conflicts of interest. I will start by TAVR. Nothing has happened much. However, there are a couple of studies which are very important to highlight that shows the progress in aortic stenosis treatment using TAVR devices. I would focus on the bicuspid. Notion 2 trial showed not only durability in tricuspid aortic stenosis treatment using TAVR over surgery, but it showed also something very important, that for bicuspid disease, we are not there yet. If you look at this slide, it shows you clearly that when you compare tricuspid to bicuspid cohort, it still shows that surgery is superior with less mortality in the cohort of the surgical arm versus the TAVR arm when it comes to treat bicuspid patients. It's the same for death, disabling stroke. The outcomes are very favorable or non-inferior for TAVR versus surgery. However, when you look and when we do the sub-analysis in the bicuspid cohort, it shows that surgery is doing better with less risk of death or disabling stroke. So for bicuspid, we are still not there to achieve safe implant with TAVR for those patients. One very important study, the SMART trial, that was comparing Evolut to SAPIEN valves, and this is the first head-to-head between the two major devices, I would say. And the importance is that this study focused on small aortic annuli. Of course, we all know that behind this study is what we all know, that we have less gradients when we use the self-expandable platform with Evolut versus the balloon expandable platform with the SAPIEN valve. But however, we don't know how this would translate in the real life. So this study has been able to show the following, that the gradient is definitely lower in the self-expandable Evolut arm versus the balloon expandable arm. And this have had a direct impact on composite score with regard biological valve deterioration. If you look at it, especially thrombosis, endocarditis, aortic valve reintervention, and the hemodynamic in terms of gradients. Now, these are where the major advances in the aortic valve treatments. When you go to the mitral, we still have a lot to learn. And as I always say, today it's still the same concept applies in surgery and transcatheter. Repair when you can, replace when you cannot, replace if you have a bad repair, and replace if the repair fails. Unfortunately, with tricuspid repair, even if you are using a MitraClip or Pascal, I will show you here that the outcomes, although they are very favorable and advancing a lot, we still have a consistent number of patients that you can see here that in whom we cannot achieve better than reducing the mitral regurgitation. And we still have a very important number of patients who have moderate to severe remaining mitral regurgitation that we have to treat despite the improvement and the advances of the devices, either with the MitraClip or Pascal, as explained in this slide here. This is, for example, in degenerative mitral disease, expanded trial in 1 year follow-up in major centers, and it still shows clearly that we still have a couple of patients, more than 10%, that in whom we cannot achieve better outcomes. And if you make a deep dive into the analysis of the results of this study, you can see that, and if you compare it to what we have had, we have seen with COAPT, Everest 2, that we still have a very important number, as you can see here, where we have a failure of the treatment or non-satisfactory treatment, especially when we treat secondary MR. Pascal from Edwards showed us some advances, especially for patients who have degenerative mitral disease. When we compare Pascal to MitraClip, it shows similar results. But we still have more than 10% of the patients, and this number increases during follow-up, in whom we cannot have less than 2+ mitral regurgitation. And I think 2+ mitral regurgitation should not give us any satisfaction to any physicians that we are when we want to treat mitral regurgitation. So we know very well that TEER is an excellent first choice therapy. However, in complex anatomy, the results are still suboptimal, with many patients who have more superior or equal to 2+ mitral regurgitation. And sometimes to achieve better results, we have higher gradients. So that's why, and this has been observed with both CLASP IID trial with Pascal or COAPT trial, as you can see it here very clearly on my result. More than 30% of the patients in the Pascal trial, and more than 30% also in the COAPT, especially when we treat functional mitral regurgitation. So we are there around, with patients, around 40% of patients in whom we cannot get a good result. So that's why we have to keep the eyes open, and 2024 have shown that there may be another place and space for other therapies. This is a unique design from Half Moon that is supposed to increase the length of the posterior mitral valve leaflet, which is retracted, and restore the coaptation, and encouraging results in the first patients has been done. The transseptal NeoCode technologies also have shown this year to become a reality, especially with CardioMEC and NeoCode experience. And again, this is something that in the coming years, we have to keep observing and following very clearly. TMVR is moving forward also, because we know that more than 50% of the patients need mitral valve replacement solutions. We know this from the surgical practice. And as I've shown you before, more than 40% of the patients would need they need better treatment than TEER, because it does not achieve the best and optimal outcomes. TMVR has moved from transapical to transseptal, although the Tendyne is still transapical approach and is the only one to have a CE mark. But we have a lot of advances in the field. I'll show you, and I'll focus on the most advanced one, Intrepid TMVR from Medtronic. It was transapical and it went transseptal now. It achieves a very nice results by eliminating mitral regurgitation, as you can see it here. It's very easy to implant. It uses a transseptal puncture, which is similar to the MitraClip, and the implant is very fast. The advantage of transcatheter mitral valve replacement is it eliminates mitral regurgitation. Look, although it's a small number of patients, but it is still significant. After 3 years of follow-up, in the majority of patients, more than 98%, there is no remaining regurgitation, which could be a game changer. And as you can see it here, this has definitely an impact on left ventricle volume, for example, and with the sustainable results over time and remodeling of the left ventricle. The M3 from Edwards is coming next year, should be the big year for this device with a CE mark. The advantage of it is like a SAPIEN S3 implant, as you can see it here. It needs a docking system. It uses a catheter, which is very familiar for all of us who are using the S3. And this valve is very promising also. As you can see it, like we have seen with the Intrepid, it eliminates mitral regurgitation. And I think, again, that this is going to be of major interest. This is a new generation device, InnoValve, that has been purchased by Edwards also recently. And new studies going to start with this device in the future. It captures the codes, it pull up the codes, said probably it will be a good solution to eliminate LVOT obstruction, which is one of the major limitations with the TMVR prosthesis. And this is also why this valve is very interesting, the Alta valve from Foci company. It sits completely in the left atrium. By sitting in the left atrium, it does not provoke or expose to LVOT obstruction. We have done a couple of valves of with this device in Bordeaux, and the results and the outcomes are really very favorable. Cephea has been acquired recently, an EFS by Abbott. The EFS is just terminated. It uses a catheter which is very similar to MitraClip. It has a very short profile, and this valve is also decreasing the number of non-eligibility because of the LVOT obstruction. So you see the TMVR, based on the limitations of TEER in the mitral space, has been advancing a bit more faster in 2024. Tricuspid is knowing huge advances, both on the surgical part, because now we can do beating heart, minimally invasive, video-assisted procedures here. As you can see it now, our tricuspid patients, when they are when they are operable, this is the way we treat them. Tricuspid transcatheter landscape has been also inspired a lot from surgery. We can do annuloplasty. It's still difficult. It's still not there. Some of the projects have been completely abandoned. Some of them are still moving, but very slowly. Of course, the dominator is the coaptation enhancement, but mainly now you will see, I will show you, orthotopic replacement is gaining a lot of interest. And of course, in some patients which are in whom treatment by orthotopic or coaptation enhancement is not possible, heterotopic replacement has a place, as some of the spacers that has been tried so far, on whom I will not focus a lot. What we have learned this year in 2024 is very, very important from the TRIE registry. For example, a very important number of patients that shows clearly that we have to treat tricuspid regurg early, but that shows also when it's better when you leave the patients with a mild or a mild to moderate, but not more than this. Otherwise, it increases the death and with bad outcomes. So if you want to choose a therapy, you have to be sure that you will have moderate and less, not more. Otherwise, the outcomes are not very good. Julian Dreyfus has published in European Heart Journal this very important paper on TRIE-score validation, and that we are using now for surgery, but also for interventional therapies. And the higher is the score, the worse are the outcomes. So from now on, all our patients should benefit from this calculation, but because it gives you an idea about the risk. 2024 was the announcement and the proof that the Lux valve, transcatheter valve, tricuspid replacement, is a major device that is playing a major role. It has a transjugular delivery system access, multidimensional fixation design. This valve comes from China. This is how it looks like. It's designed on purpose for the tricuspid valve, and not like the other devices who have been used on the left heart of the left heart, and then with whom we are moving to the tricuspid. So this is the Lux valve, a transjugular approach, much less depending on high quality imaging on echo, very quick to proceed with, very safe. And I've been presenting at London Valve these results with 1 year follow-up. And when we know that more than 90% of the valves implanted with this device are bigger than 50, which is not covered by any device so far to date, are treated with this Lux valve, we can go up to 70 millimeter dilatation of the annulus. And you can see here the outcomes are just fabulous, with less than 4% of patients who are moderate and above tricuspid regurgitation following the implant. So I think if we are failing today to show any benefit for transcatheter TEER, is because we are not eliminating the regurg, and replacement is a promise there. What I wanted to show you here is that with this valve, we have a very low number of pacemaker, less than 5%, no thrombosis that we have been observing in this trial that I showed you here with 1 year follow-up, and no bleeding, which is very favorable. The other major transcatheter replacement system is, of course, the Evoque, and which is the only one today to have CE mark and FDA approval. It's also a valve which is very easy to implant. The advantage, if you compare it, for example, with TRILUMINATE, that it eliminates completely the tricuspid regurgitation. I'll show you later this. However, with this valve, we have been observing much more severe bleeding, which we didn't see with the LUX valve, and we have been observing much more arrhythmias and conduction disorders in comparison with the other valve, and that we do not see with the transcatheter TEER, as shown by the TRILUMINATE pivotal trial here. The major advantage also of EVOQUE, as I have said, it eliminates tricuspid regurgitation. Look at the efficacy of the EVOQUE over the TEER, with almost no remaining transcatheter the tricuspid valve regurgitation. I will finish by a rapid review of the literature in TAVR. The major studies that have been published is dedicated to that, supports what we already know, that there's less stroke and death from any cause in low-risk patients in the TAVR group in comparison with the SAVR group. Notion 2 trial, I showed you this before. It confirms the durability of TAVR in comparison with surgery, but also it shows that outcomes are less favorable in the bicuspid arm in comparison with the tricuspid arm. This is a very important study from Germany, an RCT, which is ReShape 2, assessing the impact of TEER in heart failure patients in patients who have mitral regurgitation, which is moderate to severe. It shows clearly that patients who are treated by TEER, even if they are moderate, they have better outcomes in comparison with medical groups. So I think we have to start treating patients earlier than we are using. So ReShape 2 confirm COAPT outcomes in the lower risk population, which are younger, but also with moderate mitral regurgitation. The symptoms are still mandatory to follow up and to be considered when we want to include patients in this category of patients. Another very important study comparing TEER to surgery in secondary mitral regurgitation, which is Matterhorn. And although it shows no significant difference between interventional surgery, interventional therapy and surgery, it shows clearly that if it's equally effective, it's safer than surgery, as it's obviously reflected in this study. So it's not it's not better, it's not worse, but it's safer. And I think safety is a major issue in secondary mitral regurgitation that we have to observe. This is a publication also in New England Journal of Medicine with TRISCEND 2 with EVOQUE study that shows clearly what I've shown you, is that with EVOQUE, we have an improvement of functional outcomes as reflected by KCCQ, NYHA, and the 6 minutes walk-in test. And it eliminates with sustainable results over time by eliminating the tricuspid regurgitation. Very important study also in the TAVR, and I'll finish with this one, is early TAVR presented by Philippe Généreux at TCT this year, that clearly shows that TAVR is a safe and effective therapy that should and could be applied in asymptomatic patients who have severe aortic stenosis, as you can see it here, with much better outcomes in terms of death, stroke, and unplanned hospitalization reduction if you treat patients earlier than waiting for them to have clinical symptoms. So I think 2024 was very, very rich with a lot of advances clinically, but also from a device point of view. And it was very difficult for me, I'm sorry for this, to put all this in 10 minutes, but I think it's worth being listened to and observed. We are moving forward in the treatment of aortic stenosis, and in younger patients, in asymptomatic patients, and also in patients who have small annuli. We have better orientations on how to do it, when to do it, and why we should do it. The same thing for TEER patients on the mitral side, but also on the tricuspid side, with also a door which is a bit more open now for TMVR versus TEER alone, and transcatheter tricuspid replacement, which is gaining speed and more widely adopted than the TEER itself on the right heart side of the heart. By this, I terminate. I want to thank you again for your patience, and I'm sorry, apologize again for not being with you in Dubai this year, but this is a promise for next year. So thank you very much.